Good morning, everyone. My name is Ratcha Raksakmanut. I am a PhD student in oral biology, Faculty of Dentistry, Chulalongkorn University. It is an honor for me with this opportunity in this conference. Today, with my advisors, Dr. Panida, Dr. Aranat, and Dr. Varanut, we would like to share our project about oral microbiome and dental caries in toddlers. That will include the rationale, the idea, and the concept of this project, and also what we discovered so far and what's next in the future. So let's get started with the dental caries. I think probably everyone here know that dental caries is one of the most prevalent diseases in the human history. It is still the most prevalent oral disease in the world, and it is also the most common reason that people got tooth extracted. We all know that when we start to have caries, that is the sign of another caries that will come in soon. As we can see that the past caries experience is the strongest caries predictor that we have so far. To stop this, we should take a look at the starting point of the problem, the first caries. That's why we are interested in very young age kid. So let's take a look back to the very beginning. This is the caries prevalence in age 1 to 5 years old. It increased when they get older, and it increased a lot, like double when compared between 1 and 2 years old. So we should start to take care of them as soon as possible, maybe within the first year of life. And actually, this is one of the recommendations according to the Early Childhood Caries IAPD Bangkok Declaration. This is the reason that our project is focusing on dental caries in toddlers. And next is oral microbiome and dental caries. Dental caries is a multifactorial disease, and the key factors that cause caries are tooth, microbes, sugar, and time. The factor that we are interested is microbes, so let's take a look at them and see what happened during the caries process. According to the ecological plaque hypothesis, starting with the increase of sugar consumption, microbes can use sugar and secrete acid as a byproduct. The overall acid production is increased. This will create the shift in the environment to be more acidic. The consequence is the ecology of microbes in biofilm will change, and then dental caries will occur. Anyway, this phenomenon is not a one-way process. If the sugar consumption is reduced, the process will shift back to be a neutral pH. Ecology of microbes will change again, and caries active will turn back to be the healthy state. And this process can change all the time, and the change is in this community could be related to the caries progression. Dental caries is a long process disease. It is not jumping from a sound tooth to be a big hole on the tooth directly. There are multiple stages of caries during the caries process, which turn back and forth between the demineralization and remineralization all the time. At each stage, the microbes within the biofilm are different due to the change of the environment, and they can change back and forth all the time. If we take a closer look in the oral microbiome, maybe we could find some insight about dental caries. Since 17th century, we use microscope and culture techniques as a major tools for microbe study. But right now, with the new technology like sequencing and bioinformatics, for example, the amplicon sequencing like 16S rRNA gene sequencing, that we can use just some part of this gene to identify bacteria in the sample. And we can do that because this gene can be found in every prokaryote, because 16S rRNA is the structure of the prokaryote's ribosome. It has some regions that vary among each type of bacteria, which can be used for identification. And it also have some regions that are almost the same in every bacteria that make it easy to design the primers for pick it up. And then with the help of the bioinformatics, we can find which type of bacteria are in the sample and how many of them, which very useful for the further analysis. So, what we learned from previous studies that use culture-independent methods. First, because some bacteria, we cannot grow them in the lab. So, with these techniques, we can detect and classify much more species that we never known before. We also able to study the ancient samples like the fossil of calculus in the ancient skull. There was a study confirmed that the change of diet associated with the expansion of bad bacteria that promote the rampant caries after the Industrial Revolution. And when combined with other techniques like proteomics and functional analysis, they confirm that diet that we eat can change the oral microbiome. But other than that, these bugs can also change how we eat. For example, Clostridia and Prevotella species are associated with our taste thresholds. And when focused on caries, what we know so far? Well, they confirm that the oral microbiome of health and caries are different. In these figures, they show the beta diversity, which is the difference between samples. Each dot represents each sample, and the distance between them is how close and how far of these differences. So it's quite clear that samples from saliva and plaque are different, and as well as between the healthy and caries. And when looking in detail, strep mutans still was the dominant species in caries, but not every kids with caries will found strep mutans. In fact, they found a lot of other microbes that increase in caries. Some of them found increase alongside with strep mutans, but some of them are the opposite. Maybe they might help each other and live happily together, or it might play an alternative role for karyogenesis. For example, in children who never have caries before, Veillonella were identified as a predictor for future caries, but not strep mutans or other acid-producing species. In that study, they found that the level of Veillonella were correlated with the total acid-producing species. That's because Veillonella can metabolize lactate, which is an end product from catabolism by Streptococcus species that many of them are associated with caries. In this case, Veillonella may be not a caries-causing bacteria, but act like an whistleblower for caries instead, and this is the reason they were found to be a caries predictor. Other than bacteria, many microbiome data show that fungi are also associated with caries, especially in children. Candida albicans were found in the oral cavity of children with early childhood caries. And when compared with strep mutans, they were positively correlated with each other. In this study, they found much higher level of strep mutans in caries group that have Candida albicans. Another study that used multi-omics approach, they found that strep mutans and Candida albicans have synergistic relationship that involve their carbohydrate metabolism. Everything altogether enhance the accumulation of these two species in the acidogenic biofilm. So, not only strep mutants that involve the karyogenesis, and by targeting these new species and many more, this could be a promising intervention that could be applied and used in caries management. And when speaking of the different stages of caries, previous evidence confirmed that their microbiome are different, both in terms of alpha diversity, which is the diversity within the sample, like how many types of bacteria that found in each sample, and beta diversity, which is the overall difference between sample that show the dynamic of microbiome since the healthy state and change along the whole caries process. So we can conclude that dental caries is complicated, and for sure it's not caused just by a particular bacteria, and the chips in the abundance of microbiome could play an important role in karyogenesis. So how we can use this technology to improve how to take care of our patients? Let's talk about the caries management. Most of the system that we use, or even the simple decision for caries prevention, like should we give them an extra fluoride at home or apply the varnish, all of this always needs a caries risk assessment. For example, Caries Care International by ICDAS. This is the latest version of ICDAS. The concept is we evaluate the caries risk of each patient, then we can give a proper treatment and prevention for each of them, rather than use the same protocol for everyone. The important tools in this system is the caries risk assessment. The currently used caries risk assessments were excellent to identify the risk factor for each patient. But for the caries prediction, the accuracy is still be questioned. Until now, there is not enough evidence to prove that any of caries risk assessment that we have right now can predict future caries valid enough to be used in clinical practice. Most of the decision making are based on user experience and opinion. So the objective and scientific evidence prediction system might be the way to improve caries management. The question is it possible with a microbiome? Well, there are some studies try to make a prediction model by using the microbiome data. For example, this study, Tang and colleagues in 2015 built the predictive models from both plaque and saliva of 4-year-old kids and got around 80% of accuracy to predict early childhood caries onset. And another study in 2018, this time they used just 11 OTUs from plaque of 3-year-old kids and claimed that their model can predict caries onset at over 90% accuracy. And last year, from the 1 to 3-year-old kids with their saliva, this study showed that they could build the predictive model by using the overall microbiome and can predict caries at the accuracy around 85%. Behind these three studies, they all use a supervised machine learning, which the concept is we have data that we already know the label of it, usually called training group. Then we give information to the machine and let them learn the pattern of the information and create the model. Then we give another set of data, usually called the testing group, and let the model predict. So we will know how well the model is and get the accuracy of the model. And sometimes if we have enough data, we can confirm the result by give another set of data. We can call that the validation group and test the model again. For example, in this study, they used the relative abundance of 11 OTUs at the initial time point for the model training, and then they used the relative abundance of the same 11 OTUs from caries-free samples at the 6-month time point for the validation and get the result that show the possibility of each sample to be caries affected or caries-free. Anyway, all of these studies focus on the kids with the age that might be too late to improve the caries prevalence, as I mentioned before, with the only last year study that used 1 to 3 years old. But in detail, the subjects under age 2 were less than half of all subjects. So kids in different ages, they are so different and their microbiome are different as well. This study showed both alpha and beta diversity of oral microbiome from the age 2 months to 5 years old. At the age around 1 year old, the microbiome found so different when compared with the older age. The information about 1-year-old kids still lacking and it is worth to explore. So our study is about the prediction of future caries in toddlers, specifically 1-year-old kids, by using their salivary microbiome. To do that, we use 16 srRNA gene sequencing with the saliva from 1-year-old kids that at the beginning, they all were caries-free and then track their caries status for 1 year and grouping into 3 groups. First, the group that remain caries-free. Second, the group that develop white spot lesions or non-cavitated caries. And lastly, the group that develop decay or cavitated caries. Our questions are, first, are there any differences in the microbiome of these toddlers when compared between each caries status? Second, are there any biomarkers in each group that might be used to create the caries prediction model? And last but not least, can we use this microbiome data as a predictive model for the future caries of 1-year-old toddlers? In this study, we used the samples from the big cohorts. Thank you for the previous project, the impact of prolonged and on-demand breastfeeding on early childhood caries in Khon Kaen by Dr. Sirima, Dr. Varanut, and colleagues. In that project, the saliva has been collected from 1-year-old toddlers as well as the oral examinations and interviews. The whole process repeated every 6 months for 2 years long. In our study, we selected the sample that matched the grouping criteria and focused only the sample from 1-year-old toddlers and tracked the caries status for just 12 months, which we think that is the sweet spot for the prediction. So, what we discovered so far? This is a relative abundance of each group that we found. For the genus level, the most abundance was Streptococcus, followed by the Alloprevotella, Veillonella, and Haemophilus. And when compared between each group, we can see some differences in their relative abundance ratio. For the species level, unfortunately, with the limitation of the amplicon sequencing technique itself, they didn't perform very well to differentiate Streptococcus genus. But anyway, we could identify many species with different ratio between each group that we further investigate with other analyses. And when we compare between each group using the beta diversity analysis, we can see that there is a significant difference between the stay carry free group and developed decay group, which is something that we already expected. At first, we hope to find some differences in the developed white spot groups as well, but maybe the difference is too subtle. That's why there is not that significant. So for the further analysis, we will focus between stay caries free group and the developed decay group. Right now, we found some biomarkers. Those are significant difference between each group and could build the caries prediction models with a pretty good performance, but need to optimize and validate a little bit more to confirm their ability of prediction. And more than that, we are trying to reduce the number of biomarkers that need to be used as much as possible to simplify the prediction and might develop to be a simple test kit that's more practical to use in general practice. So please stay tuned for our work in the future. I would like to thank you all of my advisors, Dr. Panida, Dr. Oranat, and Dr. Varanut for all of their support and encouragement, and Dr. Sirima for her effort in the previous project and all the help that she gave in this project as well. So thank you for your attention, and for any questions, please feel free to discuss with me in the Q&A session. Have a good day and enjoy the rest of the conference. Thank you.